Hi, I'm Greg Williams. I'm the Editor-in-Chief of Wired UK. Welcome along to the Wired Expert Briefing series, a series of conversations with leaders in business, government and civil society on how the coronavirus crisis is going to impact the world in the coming months and years. We're going to be speaking to experts in a wide variety of areas to try and understand the shifts that are occurring for individuals, for organisations and for society as a whole. Today, we're going to be talking about the future of healthcare with Professor Shafi Ahmed. Shafi is a multi-award winning cancer surgeon working at the Royal London Hospital. He's a member of the NHS Assembly, giving advice to the government on the NHS long-term plan, which is the plan for the next decade. He's been awarded the Future NHS Award by MPs in 2018. He's on the faculty of Imperial, Barts Medical School, Queen Mary University, Bradford University, Harvard Medical School, and Singularity University, where he teaches innovation and digital transformation. Why I think he's particularly wired, he's probably the most viewed surgeon in the world, as he's live streamed operations using augmented reality and virtual reality as well, and broadcast them on social media. He's also done this on national TV as part of a show called Operation Live, which was shortlisted for a BAFTA in 2019. Shafi, welcome to the Wired Expert Briefing.
Hi, Greg. Thanks for having me on the Wired show. Thank you very much.
Great to have you. Thanks so much for joining the Wired Expert Briefing, Shafi. So we obviously have to talk a little bit about the shock to the healthcare systems across the world. I'm really interested to get your sense of how the resource depletion that's occurred and the fact that the systems had to sideline so many other conditions and diseases in order to cope with the challenge. How do you think in the medium and even longer term than that, what's the impact going to be of this?
That's obviously a great question. We have put other illnesses and diseases slightly to the side for the want of trying to manage this COVID-19 pandemic, which is really to take in all the resources of the healthcare system, which is obviously what we envisaged prior to the announcement of the lockdown and prior to seeing changes happening around the world. The first thing to say, of course, is that for my own specialty of surgery, that's been really impacted quite a lot, Greg, in the sense that we've had to cancel for the last about 4 weeks now of all elective surgery. That, I mean, let's just look at a few numbers. For example, if you look at on a yearly basis, we perform around 120,000 hernia operations, around a similar amount of hip replacements, about 80,000 knee replacements, about 75,000 gallbladder operations, and 50,000 other operations. So that's about 500,000 operations per year. You look at every month by month, that's equivalent to about 40 to 50,000 operations per month, which is not happening at the moment. So that's one resource that we'll have to figure out going forward, how we manage that. No one's got the answers yet. We'll have to figure out how we create capacity to allow those patients who are also suffering with their illnesses to have the proper treatment. We're also seeing patients on the medical side not being seen regularly in clinic, for example, and we've pushed on to virtual clinics for most specialties. And that's got, I think, a balance in the sense that there's an advantage here, because suddenly we realize we don't need to see every patient face to face. That's changed. We can see people more virtually, manage patients a different way, and get rid of some of the patients that don't attend their appointments, wasting a valuable resource for the healthcare system. Also, we're learning how to manage chronic diseases better, I guess, going in terms of the community and managing them remotely. So the other thing that we're seeing, interestingly, with the worry and anxiety of patients, Greg, is patients not coming into hospital at the moment because of the worry and the fear of COVID-19. I think they might be a burden on the healthcare system. Moreover, whether they may pick up the infection and may have a bad result. So for example, heart attacks, strokes, patients with surgical problems. We're seeing less emergencies, Greg, coming in. Now, where have they all gone? And where are those patients that we see on a day-to-day basis in the emergency system that aren't coming through? And what we're seeing now, a few weeks down the line, some patients have been treated with conservative treatment, for example, appendicitis with antibiotics in the community. Now seeing those patients coming in at a much later stage. So they are coming back in, but it's taken a while for them to find their symptoms, and actually probably a more advanced stage. So we have to advise people, despite the COVID-19, to come in and see people as they would normally, and don't take any risks despite the COVID-19 being a pandemic.
So this shock really to the healthcare system, it isn't just something that's occurring in the, short to medium term in terms of, managing the COVID-19 outbreak. It's going to be something that our healthcare systems are going to be impacted with for years, I'd imagine.
Yeah, no, absolutely right. I think one of the things that COVID-19 has done is perhaps bring out to the open some of the frailties that we have, some of
Yeah.
the lack of infrastructure, lack of investment over many years. And that's come to the point where we've actually noticed it, it's been discussed, and now there's more transparency over where we are. So this is interesting, of course, because suddenly now we have an opportunity. I always take these as an opportunity. I know it's difficult times. What are the opportunities that come out of COVID-19? How can we rechange the healthcare system to make it better? Which is, I think, quite a, I think that's a kind of direction that we need to figure out as a community.
One of the words that, on that note, sorry to interrupt, Shafi, one of the words that's constantly being used now is resilience. How, from your perspective, do we build that resilience into a very complex, large, under-resourced healthcare system?
I think that's a really great question, Greg. And it kind of really hits the part of our thoughts around healthcare and the kind of lack of resources that we have, which has been highlighted, as you know, both in the press and the medical community. Let's go back, let's get a few areas of what that looks like in the future. First of all, it's about the capacity of the healthcare system. That means a number of things. If we go back to the pandemic drill that was performed in 2016 by the government to look at a pandemic and how that might affect the healthcare system, a number of things came out of it. Lack of intensive care beds, lack of ventilators, lack of resources in terms of support and personal protective equipment, for example. So we did the drill, we didn't learn from that. We didn't create the infrastructure in place so that we can manage this better. And hopefully in the future, we'll be able to learn from this pandemic to manage it better in the future. Our own healthcare system has its own challenges beside the pandemic response, of course. And let's look at the staff levels. We know that we're about 40,000 nurses short in the NHS, and we're about 10,000 doctors short. We've had to rely on about 750,000 volunteers in this pandemic, and we've had to rely on about 25,000 doctors coming back from healthcare workers to support the structure, which shows where we need to be. So how do you do that? How do you improve the numbers? How do you improve capacity? Is that working different ways, more smart ways, having a smarter workforce that doesn't require the hierarchy at the moment, like doctors, nurses, etc., and other kind of trained professionals that could do similar jobs? I think we have to be more smarter by using existing healthcare workers and creating a larger workforce across different sectors, and maybe getting people again from abroad and using the global community to make that happen better. We're also short of beds, as you know. We've been starved of beds in the last 10 years with a reduction on a year-by-year basis. What's shown now that we need to have more capacity. As the population gets older, I think there is a need for capacity. That capacity has also been borne into mind about managing patients better in the community. That goes to our second point. It's that community secondary care partnership. How to make it work better so that we don't drain the resources? How do we manage patients in the community better? This is back to chronic diseases, manage them remotely, using telemedicine or using sensors or working smart ways to make that better. But of course, the whole fundamental part is to make the healthcare more efficient. We waste a lot of energy, we waste a lot of time, resources that we could use better. My example earlier about the clinics, for example, where we have a lot of people who are DNA or do not attend their appointments, thousands per day, taking valuable costs. So can we make it more efficient to use those resources more smartly? So those are the kind of things I think are simple measures to plan better, also to have infrastructure in place to manage not only healthcare that's relevant today, but also for a future pandemic that's going to happen at some point in our lifetimes.
Yeah, and I think that brings us on nicely to your work on the NHS long-term plan, which you've been involved with, which, if I understand it correctly, it was established in 2019, and it's trying to sort of think about what the next decade of the NHS looks like. How has the work that's been done thus far on the long-term plan been impacted by COVID-19? Is there going to be a lot of reassessment now? Are things going to be very different in terms of that planning?
I think we have to not change tact, but take the information from this COVID-19 pandemic to make that long-term plan, I think, more relevant going forward. So I think it'll impact the direction, but already some work's been done already. You know, it's a good plan overall. We're happy with it, but now with this kind of the fact that we've found the lack of resources, the lack of infrastructure, and the lack of kind of forward thinking, I think will come into play more for the NHS long-term plan. By long-term, of course, we're looking at next 10, 15 years, of course. But I think it'll certainly highlight people's minds now to ensure that we look at the healthcare as a whole, and look at many other facets that may not have been already in that plan at the beginning, because this is just bringing more things to mind.
So maybe the healthcare in a kind of a more holistic sense is the way that affects society in a broader way, rather than just within its own narrow confines.
I totally agree. I think it really is about the whole healthcare system, and we have to be kind of professional agnostic. And as I said before, think smarter. How does that healthcare look in 2030? What can we do better? What have we done wrong? What have we made bad decisions on? How do we overcome some of those? I always see those things as a positive, actually, Greg, rather than being negative. So, look, okay, that's happened. How do we move on? What have we learned from this? How do we make it better for people? Because that's what people want to know. People want to find solutions. I think that's kind of where we are in this kind of phase of healthcare in the UK, and certainly all around the world.
So let's look positively at some of the ways that tech has maybe been used, being able to innovate in this space. I know over many years. Let's look at telemedicine and how it's been during the crisis. Can you just give us a sense of how you think it's been useful and how it's being used, and also what you think its longer term future might be, what we've learned from its use during COVID-19 crisis?
Yeah, so that's obviously really topical and very interesting, Greg. And I'm glad you kind of raised that question. We know for the last few years, telemedicine has been there in the background. It's been there. We all know about it. People are trying to push it. And there's been some utilization of telemedicine in both primary care and secondary care, but more in primary care. And for me, what I describe telemedicine and technology in this pandemic is that this is really what I call the inflection point of humanity. But suddenly, everything's going to change for the better, I hope. Society will not be the same, and healthcare will not be the same. And telemedicine is that example that we can structure that around. As I said before, it's being utilized by a certain amount of people, but not globally. What we've seen the last few weeks, honestly, is a massive rise in utilization, 3,000, 4,000, 5,000% of use cases around the world. All the telemedicine companies have built capacity. They're at a breaking point. They're trying to get more capacity because so many patients now are trying to get telemedicine consultations. And that's a good thing. What this drives, it means that we can see people remotely. We can manage people in different ways. The expectation, the demand and the people's expectations of healthcare is changing, which needs to happen. I always thought that we may not be ready for that. It'd require this massive social engineering of society to accept that telemedicine was going to be the platform. But COVID-19 has changed that for the better. That's the first thing. But it's not just about telemedicine, it's also about telephone consultations. So for example, in the UK, the first primary contact now will be a telephone consultation or telephone triage. Yeah. I know many primary care physicians who've been using that for a few years now. Now we're seeing actually going back to telephones as the first point of contact, and then obviously and telemedicine at the same time. So we're seeing a massive use. In our own clinics at for example, the Royal London Hospital in the acute setting, we've changed. Before, we used to always assume every patient would come to see us in clinic, as I described before. Now we're running virtual clinics, making phone calls, doing telemedicine consultations, realizing not everybody needs to see a doctor face-to-face, which is what I've been saying for a long while, Greg. As you know, I've been pushing that hard. This relationship between this doctor-patient relationship has to change. It's too expensive. Human beings and face-to-face contact is unaffordable. Yeah. So how do we change that? And what I'm seeing now is what we kind of were discussing over many years, that this is the new platform. Having said that, there's a word of caution. While it's taking off and doing very well, it's not for everybody. We have to be careful about the other members of our society. For example, people who are a little bit older, who may lack the digital literacy, may actually not get the care that they deserve because of this drive telemedicine. We're also seeing this kind of, if you look at people's education, if you lack education, there's correlation with not being able to use these kind of platforms as well. That's been a correlation we've seen. And also the insurance has to change. The insurance has to change. the way
Yeah.
we benefit people and pay people. The payer wasn't paying for telemedicine consultations.
Yeah.
So they're the kind of the problems we need to overcome.
And do you see maybe that this crisis that we're in at the moment might offer us new visions for technologies that maybe haven't had widespread consumer adoption, like VR, like AR? Is that something that you're excited about and you think has real applications for healthcare in the future?
Yeah, well, yeah, I think you're right. I think this is where, so technology for me is not the solution for everything. It's merely an enabler for healthcare, but we're seeing it being used more commonly now. And also, I think the public now are more ready for rapid implementation of technology. And that, I think, is an important change.
Yeah.
So things like VR and AR, if you look at the couple of companies at the moment, because we're remote with social distancing, the issues around education training have to change. We can't be face-to-face anymore for the time being while we're being locked down. So now people are now using VR and AR training for these medical staff that came back into healthcare who need to be trained on basic life support, for example, who've been training on the wearing PPE, wearing masks, donning and doffing. So we're seeing now this remoteness of training, which is relevant. Technology, of course, is actually been really empowering the management of COVID-19, which we're happy to discuss as well.
So I'm really interested to know from you, given that you're innovating in this space, how you think the next pandemic, so it's going to be detected earlier using tech. Is that something that we're now going to be thinking about? I did a story many years ago now with a guy called Larry Brilliant, who I'm sure you know, the epidemiologist, who worked on smallpox in South Asia. And he was, this is about 5 or 6 years ago, was working on a smartphone app, basically, that enabled people in rural Thailand and other areas in Southeast Asia to do a very simple health questionnaire every day about their own health and the health of their livestock in order to try and detect any kind of disease very, very early on. Do you think we're going to be seeing a lot more of this kind of use of technology in these kind of ways that are in many ways quite straightforward, quite simple? They're just ways of noticing things much earlier than we have done recently.
I agree. I think that we are going to see technology be used to not just prevent these kind of pandemics, but to manage them once they've been highlighted. So let's take a few examples of Southeast Asia, Greg. And for me, I often say this quote to people about this pandemic: this is a global pandemic requiring global solutions. It has to be that. We're missing some of the conversations because we're very much insular. Each country does its own thing and not learning from the bigger piece. The WHO, for example, China, South Korea, Singapore, Taiwan have shown us almost how to manage an epidemic. They've had experience through SARS before, through Ebola virus in Africa, and MERS, of course, more recently. What they've done, of course, is put things in place where you highlight cases very quickly. And they've gone through this process of scientific rigor, which of course is you identify by testing the people, you isolate them, you do you look at their social contact and trace them. Again, you test and you isolate. That's kind of the parameters of pandemic, of course. But then that gives rise to use of technology, mapping the population, using their data to figure out, highlighting where they are, who they're close to, trace them very quickly, allowing them to get the tests appropriate at the same time, having a database, simple measures that suddenly plan the treatment very effectively. We talk about the things like temperature gauges and infrared technology, looking at people, recognizing where the illnesses are. But these are simple measures, not advanced technology that manages pandemic. So I think those are the things we'll be seeing used much more routinely, quickly, much quicker than we have done already this year in the future.
So you've been working in Bolivia over the past few years in terms of building the hospital, the healthcare facility of the future. Tell us a little bit about what you're thinking in terms of those long-term trends in what the facilities of the future are going to be like and how they're going to be different maybe to the ones that we currently have.
Yeah, so that's I have been working with the Bolivian team for about a year and a half now, I guess.
Yeah.
And that project is almost in fruition. The hospital is opening in Q3 of this year, so my kind of work is done. My role is about advising them, okay, if you have a country like Bolivia, for example, which is not affluent, one of the poorest countries in South America, they have a rural community. They have also an urban community based out in La Paz, which is 10,000 feet, and Santa Cruz, which is much lower, where the two masses of people are. They have less capability of connectivity. They're still struggling with 3 and 4G, for example. So you understand, where could they be in the next 5, 10 years? Should they be learning from the first world countries, for example, US and others, about the healthcare system, or could they actually reimagine it? You create a blank canvas. Okay, what do we need? This is where technology is part of the solution. I said before, it's just an enabler. So where does tech fit in? So first we put infrastructure in. We built the hospital, we put the best cabling in, best connected devices in, so that we had a capacity for the future to build. We bought the best systems for CT, for electronic health records that we could build on, so that we're future-proof. That's the first thing you do. Then you make the hospital have good governance, sound governance today. Yeah, but build on technology in the next 10 years, introduce them with the community and the government and the local hospitals slowly, so that you encourage that change of direction. I think COVID-19 will help their hospital translate much faster, as we've seen already around the world about using different kind of healthcare practices. Use telemedicine, use data-derived healthcare. You personalize it much better for them. You make the experience better. The experience of hospital is still, I think, archaic. It's still old-fashioned. Can we do better with the user interface? You know, let's sound like from an engineering point of view. Can we change the user experience, the user interface? Of course we can. All those things, I think, are the way to imagine a hospital in the future. And we always think about hospitals getting bigger and bigger and bigger. And you see amazing hospitals, for example, with 5,000, 6,000 beds. But actually, we should be thinking about smaller hospitals, contained, having more in the community, make that whole primary, secondary care, social care better. So it's more about the concept, as we said at the beginning, of holistic care. How do we prevent illness? How do we treat people better? How do we make it more accessible? These are the kind of things that simple solutions, but actually are almost most complicated to deliver, but actually will form the basis of the hospital of the future.
Right, to that move almost from acute care to managing kind of chronic conditions and managing a lot of that by using data and new ways of using network technology. A couple more questions, Shafi. Obviously, you've talked a little bit about Bolivia. You've talked about South Asia. I'm really interested to get a sense of how you think medical research will be conducted moving forward. Clearly, the kind of geopolitical response has been lacking to COVID-19. There hasn't been this transnational sharing of information and data, and maybe the way that it should have been. Do you think that this really, the takeaway from this is that we just have to be able to deal with these pandemics in a truly international way and transnational way if we're really going to try and ensure that we are rid of this in a meaningful way?
Yeah, I think you've answered the question already, Greg. I think of course we have to. And you're right, looking at the limitations so far of what we've done on a global level. So a few things to say about research. So research also needs to be disrupted. And I've been saying that for a long while. If you think about the standard randomized controlled trial that we've gone to for many decades as a way to make change, it's quite time consuming, it's laborious. It can take 7 years for a randomized controlled trial to show the results and for translation. The world will move on 300 years, no 7 years almost, right? We kind of become obsolete before we realize. What we have seen globally though in research is collaborations of multi-center trials at pace to pick up the amount of patients required to power the research to the right level. So for example, in my own field of surgery, we've seen lots of surgical institutions getting together to bring patients to the forefront, to rapidly increase the size of the trial and to show the significance. In the context of pandemic this COVID-19, there's again a surgical called COVID Surge 19 trial going on, looking at the complications and the outcomes of surgical operations in the presence of COVID-19. That's one thing we see globally. Secondly, we've obviously seen the whole, I guess, the excitement and enthusiasm of some countries around hydroxychloroquine and azithromycin as maybe drugs that we could use for COVID-19. Obviously, that was based on a small paper in Marseille by Professor Raut on 36 patients who may have benefited. And this has gone viral, as you know. So we don't actually have the evidence for those medicines. That's the first thing. We can't recommend them. But what we are seeing now is quick randomized trials. So in New York, for example, 1,000 patients have been recruited at pace. We're seeing trials in South America, and also the recovery trial in the UK between Barts and there are 3 other hospitals looking at rapidly increased numbers, sharing the data immediately so that we can make changes and not wait for a 3 or 4 month cycle. So we are seeing, I think this will allow us to reimagine the way ethics is done very quickly, the way we recruit patients at pace, deliver the data to the vast population so that people make decisions. But back to the forefront, of course, we need to do better globally. This collected data points are not there. We have millions of data, Greg, from China, from Taiwan, from Singapore, from Italy, from Spain, from America now, from UK, France and Germany. If we had all that data together, we'd have 50 to 100,000 patients who've gone through the system looking at variables to make improvements. And sadly, we're not seeing that at the moment.
There really has been, I think, a failing in leadership around that. But we're pretty much out of time. Shafi, one final question for you. Can you just share with us what you think are going to be the big trends that are going to come to the healthcare industry over the next year or two because of COVID-19? What are we really going to notice?
So I think the first thing we're going to notice is the change of the way we interact with our patients. That's going to evolve. And I said, as we were mentioning earlier, Greg, is that human interaction will change. It'll be more through telephone, more through telemedicine. We'll accept the first point of contact will not be face-to-face contact. That will be less expensive. It'll make healthcare more affordable. We'll be managing our base better. Secondly, I think we'll see changes in the way we manage the chronic diseases. The way we treat our patients, maybe monitor them remotely, using the data, for example, much more in a sophisticated manner, so that people get a more personalized approach. We know that AI is coming in. AI and data-driven healthcare is going to be the hallmark of healthcare in the next year or so. And AI we talked about a lot over the last few years, and it's promised a lot over the last few years, but delivered very little. I think 2020 and going forward, I think we'll see real-time translation of AI healthcare solutions, whether it's in imaging, whether it's managing patients better, whether it's even the contact we have with our healthcare service. So I think fundamentally, with those kind of broad changes we'll see, I think most importantly is that the expectation will change. I think that's important, actually. I think that's underestimated. The expectations of the healthcare workers, the expectations of the patients, governments, politicians, and healthcare providers will change. And that will offer the right conversations to improve the healthcare for all of us, because that's been a big barrier for adoption and big barrier to change.
Shafi, thank you so much for sharing your thoughts today on Wired Expert Briefings. Always delighted to chat to you and to learn how you're innovating in this space. Thank you for your time and thanks for the work you do.
Thank you so much, Greg.
Thanks, Shafi.